Namaste Betiya. Hamesha Khush Raho Betiya. A very good morning to you all. Myself, JVM Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, JAIPUR. In the last lecture, we have discussed about the adrenal gland, its introduction and the hormones related to it. I believe you must all have gone through the anatomy and physiology, and you must have learned about the normal anatomy and physiology of the adrenal gland. In today's lecture, we are going to start with adrenocorticotropic hormone, its types, the etiology, clinical features, investigation, and the management. Today, we are also going to discuss one of the important disease, that is the Cushing Syndrome. It is very important from the examination point of view, because Cushing Syndrome is asked many times in the examination. So let's start with the adrenocorticotropic hormone, and then we are going to discuss about the Cushing Syndrome. So ACTH, it is secreting corticotropic cells. It consists of about 20% of the pituitary cell population. Now, ACTH is secreted in a pulsatile manner, that is known as the circadian rhythm that we have discussed in the last lecture, that it is more in the morning, and it is less or very small quantity of hormone is released during sleep. So this pattern is known as the circadian rhythm, peaking at around 6 a.m. and reaching nadir or very minute quantity at around midnight. So the ACTH levels are increased by the physical and physiological stress. So whenever there is any kind of stress, like physical stress or physiological stress, the ACTH level, the secretion of the ACTH is increased. It is also increased with the exercise, acute illness, and insulin-induced hypoglycemia. We also have feedback regulation through the hypothalamo-pituitary adrenal axis. So the ACTH levels are increased by the physical and physiological stresses, and exercise and acute illness, insulin-induced hypoglycemia. So there is a feedback regulation of this ACTH secretion is through the hypothalamo-pituitary adrenal axis. Now, what are the actions of ACTH? The ACTH is required to maintain the metabolic homeostasis and mediate the neuroendocrine stress response. So ACTH, as we all know, it is secreting corticotropic cells that constitute of 20% of the pituitary cell population. It is secreted in the pulsatile manner, that is known as the circadian rhythm, maximum in the morning and minimum at night. And the level of the ACTH is increased during the physical and physiological stresses, exercise, acute illness, and insulin-induced hypoglycemia. There is also feedback regulation through the hypothalamo-pituitary adrenal axis. Now, what is the action of ACTH? It helps to maintain the metabolic homeostasis and mediate the neuroendocrine stress response. So this is actually required for the stress response in the body. Now, what are the normal levels of the ACTH in the body? The normal level is 1.3 to 16.7 picomole per liter, or 6 to 76 picogram per ml. The normal cortisol level in the body, it is during fasting from 8 a.m. to 12 noon, it is 5 to 25 microgram per deciliter. From 12 to 8 p.m., it is 5 to 15 microgram per deciliter, and 8 p.m. to 8 a.m., 0 to 10 microgram per deciliter, because it is secreted in the pulsatile manner during the different part of the day, that is known as the circadian rhythm. Now, what are the deficiency diseases or the symptoms that are produced by the deficiency of the ACTH hormone? Secondary adrenal insufficiency as a result of pituitary ACTH deficiency, it is characterized by the following signs and symptoms. So ACTH deficiency, if it is present, it is characterized by fatigue. The patient is having a lot of fatigue with weakness. The patient complains of weakness. There is anorexia, nausea, vomiting, and occasional hypoglycemia. So the adrenal insufficiency, and as a result of pituitary ACTH deficiency, is characterized by fatigue. There is weakness, anorexia, nausea, vomiting, and occasional hypoglycemia. So there are complaints of fatigue, weakness. The patient remains very much tired. There is weight weakness. There is anorexia, no desire to eat, with nausea, vomiting, and occasional hypoglycemia. In the lab diagnosis, how can we check for the reduced level of the ACTH? We can check for the low ACTH levels. there will be low serum cortisol levels. Now, how to treat a case of the decreased ACTH levels? We have to give the glucocorticoid replacement therapy, and we can give prednisolone 5 milligram each morning in the individual who have deficiency to all these to the ACTH. So lab diagnosis consists of low level of the ACTH and low serum cortisol levels. In the treatment, we can give glucocorticoid replacement therapy and prednisolone 5 milligram each morning. Now, today we are going to discuss with another important disease, that is the Cushing syndrome, or it is also known as the ACTH producing adenoma. So Cushing syndrome is asked many times in the examination. So let's discuss about the Cushing syndrome, and it is a very important disease and today's topic. So Cushing syndrome, what is the etiology? Cushing syndrome is basically caused due to the excessive production of the ACTH, and it can be caused because of the tumors, different type of tumors that are secreting excessive of ACTH in the body. So etiology is dependent on the site from which there is excessive production of the ACTH. So Cushing syndrome, we have ACTH producing adenoma. The etiology consists of pituitary corticotropic adenomas. There can be tumors from the pituitary corticotropic secreting cells. There can be iatrogenic hypercortisolism. Iatrogenic hypercortisolism that is occurring due to the intake of the medicines that are producing excessive of cortisol. There can be ectopic tumor. Ectopic tumor means any other site other than the normal site, a tumor is present and those cells are secreting ACTH hormone. It can also be caused due to the cortisol producing adrenal adenomas, and other causes includes adrenal carcinoma and adrenal hyperplasia. So in the Cushing syndrome, we have ACTH producing adenomas that consist of the etiology. We have pituitary corticotropic adenomas, iatrogenic hypercortisolism, ectopic tumor with ACTH production, cortisol producing adrenal adenomas, and adrenal carcinoma and adrenal hyperplasia. So these are the various causes that are responsible for the excessive production of ACTH. Now, what is the prevalence of Cushing syndrome? Cushing syndrome, it is accounting for about 10 to 15% of all pituitary tumors. And it is 5 to 10 times more common in women than in men. So prevalence is around 10 to 15% of all the pituitary tumors, and it is 5 to 10 times more common in women than in men. In the clinical features, because this is a syndrome, so it is characterized by a large variety of the symptoms. So in the clinical features, you will observe thin skin, there will be central obesity. So the skin will be thin, there will be central obesity of the individual. The patient will also complain of hypertension, that is increased blood pressure. There will be plethoric or moon facies. The patient can be plethoric, that is full of blood, and moon facies means moon-like faces there. There are purple stria that is observed on the abdomen with easy bruisability. The patient will also complain of glucose intolerance or the diabetes mellitus. There can be gonadal dysfunction with the reduction of the bone mineral density that is leading to the osteoporosis. There can be proximal muscle weakness and signs of hyperandrogenism that includes acne and hirsutism. There are various psychological disturbances that could be seen in form of depression, mania, and psychosis. So in the clinical features of Cushing syndrome, we will have thin skin, there will be central obesity, hypertension, plethoric moon facies with purple stria and easy bruisability. The patient will also complain of glucose intolerance or diabetes mellitus, and there will be features of gonadal dysfunction, osteoporosis. There will be proximal muscle weakness. There will be signs of hyperandrogenism that includes acne and hirsutism. Hirsutism is abnormal hair growth at the site where it should not be present, especially in case of females. Psychological disturbances will be seen in such patient, which includes depression, mania, and the psychosis. In the Cushing syndrome, there are various hemopoietic features, which includes the leukocytosis, that is increase in the WBC count. The patient will also complain of lymphopenia, that is reduction in the lymphocytes. There will be eosinopenia, and there will be immune suppression that includes delayed hypersensitivity and infection propensity. So there will be various hemopoietic features that will be present in case of Cushing syndrome. That will include leukocytosis. There will be lymphopenia. eosinopenia, and immune suppression that includes delayed hypersensitivity and infection propensity. Now, what are the various lab investigations that could be done in case of Cushing syndrome? In the Cushing syndrome, we have to measure 24 hours free cortisol level, and that can be calculated through the urine. Means we are collecting 24-hour sample of the urine, and then we are checking for the cortisol level in the urine. We can also check for the mean basal ACTH levels. These are 8-fold higher in the patient with ectopic ACTH secretion than those with the pituitary ACTH secretion. So in order to differentiate the various sites, whether it is ectopic or it is normal ACTH secretion, normal site ACTH secretion, we have to check for the mean basal ACTH levels that are 8-fold increase in the ectopic ACTH secretion. Now, there are various imaging techniques that could be used in the case of Cushing syndrome for the detection of the excessive for detection of the sites that are secreting ACTH hormone. So we can go for the pituitary MRI to detect the microadenoma. So we can check for the pituitary tumor, or we can go for the MRI that will detect the pituitary tumor or microadenoma. We can also go for chest radiographs. In the chest radiographs, there will be ectopic ACTH syndrome, and most tumors are located in the thorax. We can also advise the patient to go for the CT scan. In the CT scan, there will be adrenocortical tumors that are easily viewed. So in the imaging techniques, we can go for pituitary MRI to check for any microadenomas. We can see the chest radiographs for ectopic ACTH syndrome, and most tumors are located in the thorax. We can also check for the CT scan that will provide us with the adrenocorticotropic tumors that are easily viewed. Now we come to the treatment part. How to treat a case of the Cushing syndrome? Whenever a patient of Cushing syndrome is coming to you, you can do the selective transsphenoidal resection. So selective transsphenoidal resection can be done in the patient. And after the successful tumor resection, means we are removing the particular tumor that is secreting excessive of ACTH. So after the successful tumor resection, most of the patient experience a post-operative period of symptomatic ACTH deficiencies. So after the resection of the tumors, most of the patient are experiencing post-operative period of asymptomatic ACTH deficiency, and it may last for up to 12 months. This usually requires low dose of cortisol replacement. Now, in case of, we can also go for pituitary irradiation after unsuccessful surgery. If the surgery of selective transsphenoidal resection or tumor resection is not successful, then we can go for pituitary irradiation, but it cures only 15% of the patients with tumors that are secreting ACTH. We can also do metarapone. We can also administer the patient metarapone that normalizes the blood plasma cortisol in up to 75% of the patient. So in the treatment, we can go for selective transsphenoidal resection. We can also go for the tumor resection, and after the tumor resection, there is a deficiency, post-operative deficiency of ACTH for around 12 months, and for that we have to supplement the low dose of cortisol. The pituitary irradiation can be done in case of unsuccessful surgery, and metarapone, it normalizes the blood plasma cortisol in around 75% of the patients. So this was all about the ACTH secreting tumors and the Cushing syndrome. Let me once again give a quick review of the various symptoms that are produced due to the Cushing syndrome. I've also given a picture of the Cushing syndrome baby or individual on the portal in the e-notes that I've uploaded, so that you can just have a quick review of that. And I'm now just revising the symptoms that I have given on the picture of the Cushing syndrome. So there will be thinning of the hair and hirsutism. The patient will have acne and facial plethora. There will be complaints of psychosis, and there will be cataract with mild exophthalmos. The face of the individual will be moon faces with facial plethora. There will be hypertension, that is increased blood pressure with central obesity. On the abdomen, there are different development of the stria, purple stria that you are going to see. The patient will also have peptic ulcer with loss of height and back pain from compression fractures, because compression fractures are appearing due to the reduced bone mineral density and the osteoporosis. The patient will also have hyperglycemia, that is diabetes mellitus, and there will be menstrual disturbances. The patient will have the great tendency for fractures, and there will be increased skin thickness. with weakness and wasting of the muscles with proximal thigh muscle weakness. There will be osteoporosis and bruising of the skin. So there will be stria on the skin and bruising of the skin. There will be great tendency for infection with poor wound healing and little inflammatory response. So this is all about the Cushing syndrome that we had to discuss today. Now it's your homework to go through the e-notes that I've uploaded and check for the various things that I have covered. You should also go through the book and check for the answers to the question that I have given you on the portal. So this was all about the Cushing syndrome today. In the next lecture, we are going to discuss about the Addison's disease. So this is all for today. We will be meeting in the next lecture tomorrow. This session is powered by digital version 2.0, JAYOTI VIDYAPEETH University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.